So I'm going to be talking about cardiac arrest and the reperfusion injury that we confront when we have our survivors of cardiac arrest move into the intensive care unit. And I'm going to be discussing some emerging concepts regarding neuromonitoring and some emerging concepts regarding the window of injury. I had always assumed that when you're pulseless and apneic out on the sidewalk during a cardiac arrest, that's when the damage is happening. And that once you get to ROSC, the period of active injury is now done. And our role is really just to support the patient thereafter to see if they wake up or not. This concept has changed radically now. And we know that actually a cardiac arrest, which gets to ROSC, a return of spontaneous circulation, triggers an explosion of secondary injury in the brain that lasts for hours and even 2 to 3 days. And this is a time period, a make or break period, where we can continue to up our game and try to get improved survival to discharge with good recovery. So I'm going to be talking about some key concepts. And the first one is, obviously, when the arrest patient first comes in, they often look terrible. They're flaccid, deeply comatose. Pupils can be minimally or unreactive. But at that point in time, you don't really know anything about what could happen down the road. The brain literally can be stunned. And some of this very early loss of neurologic function can rapidly bounce back. So you never want to jump to conclusions on arrival that some patient's basically done for and that you can't do anything. Our approach to cardiac arrest in the intensive care unit, we tend to have a very high-tech approach. And really, we're not treating the period of ischemia. We're treating what we call the post-cardiac arrest syndrome. In effect, we're treating and modulating a reperfusion injury to the brain and, in fact, the entire body. And one of the important processes that's triggered by the 20 or so minutes that the patient was getting very low amount of perfusion and oxygen is that it can trigger apoptosis in cells that are still alive and hanging on for dear life. So the next concept, again, just to reinforce what I said before, is that fires are burning in the brain long after ROSC, again, for hours or days. So I'm going to show you some data that we generated when I was at Columbia a number of years ago, where we started to put multimodality monitors into the brains of our cardiac arrest patients admitted to the neurological ICU. At that time, this was our bundle, is what we called it, a triple lumen bolt with intracranial pressure, brain oxygen, microdialysis, and then a second dual lumen bolt with intracortical EEG and a CBF probe. And here's an example of what these probes look like. These were put in under standard clinical consent, and then the patients consented to allow us to collect and analyze the data post hoc. So the first set of measurements, very interesting in this initial cohort of 15 patients, was, what do we see at baseline? A normal ICP, we see marginal, just to the lower limit of normal brain oxygen levels, very low cerebral blood flow levels, which we think is largely coupled to reduction in metabolism, and already an elevation in the lactate pyruvate ratio, indicating ongoing oxidative stress. When we look at the patients that went on to recover and do well and follow commands, here's their brain oxygen levels. So we see among the people with severe injury who ended up having dying largely from withdrawal due to poor neurologic status, there's a lot of brain tissue hypoxia, a lot more, especially on the first and second day. So there's early brain tissue hypoxia, and maybe this is a target for therapy. What we found later on, the same two groups, is that after the brain oxygen levels normalize, that's when we see the separation of the lactate pyruvate ratios and more metabolic distress, basically, and shift to anaerobic metabolism in days 4, 5, 6, and 7. there may be a whole universe of ongoing secondary injury, electrical injury in cardiac arrest that we still don't even see or know about with standard techniques. Well, to summarize, what we were able to document in this cohort was that brain tissue hypoxia was temporally related to systemic O2 desats, sudden drops in blood pressure, ongoing seizures, and even in some cases, paroxysmal central hyperventilation. We also saw episodes of seizures leading to glutamate elevations. We saw brain glucose levels dropping due to systemic hypoglycemia. And I just mentioned the SDs. So indicating again that there seems to be an extensive window of secondary injury, and we need to start to think more about early monitoring. So my next concept is that hypothermia truly is a game changer. We're talking here about TTM. So here's a list of the various factors that might influence outcome after an arrest. And the top 5, we can't do anything about, right? When we work in the ICU, we know witnessed arrest, early onset of high quality CPR, shockable rhythms do better, younger people do better in general. The one thing that we can actually modulate, again, is the body temperature when they come to the ICU. And I'm not going to go over the HACA study and the various basic science that backs up why cooling the brain and body is beneficial after cardiac arrest, but it is the standard of care now. It's in our guidelines, and it's recently, as you know, been expanded beyond the VFib, VTAC patients, now to even the non-shockable rhythms, if you do careful patient selection. So what's happened is that TTM opens up possibilities. It's given us an open mind and a forward way of thinking about this terrible form of brain injury, which we used to think of as decades as the world's worst form of brain injury, a completely untreatable form of brain injury. And now we see it as something where we've made tremendous advances in recent years, and we're thinking now all the time about how can we continue to improve. Right now, worldwide, about 10% of patients that make it to a hospital after cardiac arrest are discharged alive. Many of them, the majority in fact, actually have surprisingly good neurologic outcomes. But we can do better, and that's what we're talking about today. How can we do better? So what we want to do is basically wipe out therapeutic nihilism and replace it with hope. Because when you've got a treatment that you know can help neurologic outcome, what I have observed is that it then opens up minds towards other more aggressive forms of cardiac support. There's no better example than a patient with a clear STEMI with hypoxic ischemic encephalopathy. In the old days, the cardiologist would not take that patient to the cath lab and they would die. They'd say, well, why would we want to fix the coronaries of a guy who's never going to wake up with terrible brain damage? So now we have the hope, and now patients are routinely going to the cath lab, going on advanced mechanical circulatory support, and we're starting to see even the use of ECMO, or so-called eCPR, starting to be incorporated around the world into cardiac arrest protocols. So I'm going to switch gears now and talk a little bit about what we used to know about prognosis after cardiac arrest. This was a very influential practice guideline published by the American Academy of Neurology in 2006, and it generated this figure, a somewhat famous figure at this point. It effectively replaced the classic David Levy study that was in JAMA in the early 1980s. And the point was, in cohorts of cardiac arrest patients, they identified certain findings that, for all intents and purposes, indicated absolutely no hope. Myoclonic status epilepticus, if it occurs at all, absolutely no hope. Absent N20 responses on somatosensory evoked potentials, if they're both absent starting on day 3 or later, almost absolutely no hope. neuron-specific enolase elevations, or very poor neurologic exam on day 3. Well, the thing is, this data was generated prior to the widespread use of therapeutic hypothermia, which really started to break out, I'd say, in Europe and the US around 2007, a few years after the seminal studies were published. And so this is an editorial that I wrote a while back, basically talking about new game, new rules. What effectively happened in the literature, including a publication by Dr. Rossetti and others, is that effectively new reports were coming out of people that had been cooled with absent N20 responses who then woke up anyway, with very elevated NSC levels who had been cooled, who then woke up anyway, with very poor examinations, out to day 2 or 3, absent motor, right? Unreactive pupils, who then woke up anyway. And so what it really led to was a kind of a softening of what had been published really as law, as a mandate, as a practice guideline. Now, after the era of TTM is now with us, all of these hardline predictions that we had with the presence of certain poor prognostic variables now had to be softened. So now we know status myoclonic, status myoclonus, 9% of these patients can actually wake up and walk and talk. We've seen other examples with the SSEPs, no longer absolutely poor outcome, probably poor outcome, probably poor outcome, probably poor outcome. So again, a softening and an opening of the mind, if you will, about the possibilities that we're looking at in the future. So now I'm going to talk about the modern era of how we prognosticate in our cardiac arrest patients. The role of the neurologist obviously had always been call them on day 3, let them do their tests, and give us some kind of thumbs up or thumbs down. Is this guy ever going to wake up or not? Well, the current state of the art has really zeroed in on 5 different modalities that can assist the neurologist or intensivist in assessing the final extent of outcome and the longer term prospects. Clearly, clinical exam off sedation on day 3, EEG, SSEPs, biomarkers, and we basically have NSC right now as validated, and then MRI scanning. I'm going to touch on them all very briefly. In terms of the neuroexam, absence of both pupils and corneals out at 72 hours still really is obviously very poor finding. Majority of patients will not do well, and now it seems to be turning out that maybe target temperature or TTM doesn't really affect. This is a predictive variable. Again, about the SSEPs, we have seen false positives now in cooled patients. And one of the key things you're going to hear about is that continuous EEG, beyond simply identifying the so-called malignant patterns of people who are not going to do well, we're now learning that early EEG with early recovery of EEG findings towards normal can actually identify at a very early point the people that are going to do well. So as the EEG recovers, then maybe so as the patient will recover. These are the various flavors, if you will, of the so-called highly malignant EEG backgrounds, pure suppression, suppression with periodic discharges, burst suppression, and burst suppression with superimposed discharges. Another important theme you'll hear is that the trend on the background is important. As the background improves and normalizes, again, that's good. If the background's deteriorating over time, that's bad. And none of these modalities alone, though, seems to be perfect. It's the combination that really gives us the very best picture. This is just one study, again, showing survival curves among patients with the very highest quartile of measured neuron-specific enolase at 48 hours. They do really badly. And you see here with the lowest levels, quite a few of these patients, at least in this one study, had very nice survival. So the cut point these days in patients that get TTM for reasonably good identification of people with unrecoverable injuries is up closer now to about 80 micrograms per liter. And finally, MRI. The magic number we have been told about was 10% of total brain volume if it's ischemic on DWI. That's indicating probably a bad outcome. But incredibly, in the best of these studies, you actually have to have ischemic damage to 22% of your brain or more to be 100% sure that an individual has no chance of recovery. So let's talk now about the future of neuromonitoring for the next few minutes. And first, I'm going to talk about EEG and the concept of rapid response or emergency headband EEG. The concept is this. I mean, most hospitals around the world today, we get EEG hookups, maybe, very often spot, sometimes continuous, but we're often getting it started up maybe 2 or 3 days after the onset of the injury. So the best paper that I can show you, and this is the paper that really opened my eyes to the promise of early EEG, is this study of headband EEG from Japan. And this is a series of cardiac arrest patients on top with good neurologic outcome and a slightly larger group with poor neurologic outcome, many of who died, again, from withdrawal of life-sustaining treatment or who never recovered consciousness. These red bands are seizure activity detected by the EEG, right? You see here, the majority of these hookups started within 4 hours after ROSC. And you see here that when the patients have the seizures with the red bands, right, they're all in the poor neurologic outcome with one exception. So overall, they found status epilepticus in 22% of these cardiac arrest patients. The data showed that the seizures began as early as 4 hours and as late as 40 hours after ROSC. And the data showed that only 1 of 28 of these patients with status on EEG recovered consciousness and had a good outcome. So that's an association. And many other studies have shown this. The question is, are these seizures mediating or driving secondary brain injury? So I'm going to show you this data from one patient, a case report, again, that my group published. It was published in what's now called JAMA Neurology. And this was a proof of concept. I had always thought if seizures are doing what we think they should be or would be doing, the seizures should lead to increases in cerebral blood flow, while at the same time sucking up the oxygen and driving brain tissue hypoxia. This was a guy that came in after cardiac arrest. He got the brain monitoring bundle, and we got a late EEG hookup, and we did not know that he was in florid status epilepticus. We easily terminated the status with 2 grams of IV Keppra. And what we saw is that the brain was experiencing these surges, somewhat prolonged in brain tissue hypoxia that normalized as soon as the seizure stopped. And the cerebral blood flow was surging up during the seizures, which normalized at a lower level as the brain calmed down, as you'd predict. And there were also little measurable surges in intracranial pressure, vasodilation, and even brain hyperthermia with the seizures. So proof of concept that it's very, very possible that these seizures are very damaging to the brain. So the final concept I want to leave with you is that, and this is not widely accepted, this is not what we consider to be what everyone should be doing right now. This is what I think will happen one day, which is that one day we're all going to understand that cardiac arrest demands emergency EEG. Now, obviously, in order to get there, we need more research. We need to test this concept and do studies where we are trialing more emergency EEG to replicate the findings from the Japanese studies and look at some of the other relationships and dynamics. So if you're not familiar with what a Ceribell looks like, here it is. It's hooked up to Wi-Fi. The EEG is displayed at the bedside. Anybody that's got a login can read it through a web portal, and it's connected to seizure detection software, so it can literally give a bedside alarm if at least the algorithm thinks that there might be ongoing seizures. Similar concepts are now on the way with the use of non-invasive brain oxygen monitoring, because let's face it, drilling holes in the head of cardiac arrest patients, although fun, never really is going to become a standard of care, and it may not be necessary actually with some of this technology. Here's sort of a concept of what we're trying to do. In the case of this sensor, we're measuring the regional oxygen hemoglobin saturation of the brain tissue, subtracting out venous circulation in the scalp and skull. And in this small study by Samparnia, they found that higher regional O2 sats did occur in the patients who had a good neurologic outcome. This is a study that my group recently published looking at a different device called the C-Flow device. They integrated a laser with near-infrared, and in this case, it didn't really work. It did not truly separate out the perfusion indices. Were not able to identify patients that were going to have a better outcome. So it's emerging technology, but it's an attractive treatment philosophy about doing early neuromonitoring. Other promising modalities include pupilometry. This is what a pupilometer does. This is more of an intermittent or snapshot form of monitoring, but a very nice publication by Moro Odo and colleagues did show that very poor pupillary reactivity, if it occurred actually at any point during serial monitoring of pupillary responses, if it was very poor, seemed to have prognostic value as well. And early reports are now even looking at optic nerve sheath diameter on the idea that an injured brain may have more cytotoxic edema, leading to subtle increases in ICP that can be detected by ONSD. So finally, in the last minute, if you're not aware, the 2020 new guidelines for CPR and emergency cardiac care just came out. And it's very, very interesting for us neurointensivists, because for the first time, EEG monitoring has been acknowledged on the base of the current evidence as something that we should be doing in all of our non-command following or brain injured cardiac arrest patients. This whole idea of doing very early EEG is a very new concept where it hasn't even really been addressed yet. But if you think about it based on the data that I've discussed today, it makes sense. So here's a nice figure in this highlight, if you will, or pictographic, showing the role of electrophysiology. So I would change it and I'd make it look like this. And I'd say, you know, if you're going to get a head CT off the bat, why don't we start thinking about early rapid response EEG? We can do it easily in the middle of the night. We can then convert to a conventional 1020 hookup in the morning. And let's start to see if we can get early detection of ictal activity and find out if early treatment can actually reduce brain damage and lead to a better outcome. It's a new era. We used to talk about CPR, cardiopulmonary resuscitation, and now it's all about the brain. It's all about CCR, cardiocerebral resuscitation.